The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. This program, we pre-record for now. We used to be live on a Wednesday night, and you're probably looking at this on a Wednesday night or Thursday or Sunday night. It's pre-recorded, and we very intentionally call it Your Health, Your Choice, because again, we aim to give you accurate medical information, scientifically based medical information, so that you can make the right choices for your health. Last week, November the 14th, was World Diabetes Day. And I didn't have the opportunity to play a diabetes program last week. So I decided this week and next week, we will focus on diabetes, and specifically type 2 diabetes. We know that diabetes is an epidemic, and we are conscious that here in Trinidad, the prevalence of diabetes is rising rapidly. I just want to bring up slide 4 on the PowerPoint, slide 4. And what this shows you is the spread of diabetes right throughout the world. It's a nice diagram with different colors. And you see the African continent still has a relatively lower incidence and prevalence of diabetes. But as affluence begins to spread in westernized countries. If you look at Europe and you look at the UK and especially America and Latin America, you can see the lighter colors, but you can see some colors even going a light green color, indicating that the prevalence of diabetes is getting up to 20%, 25% prevalence in some of those countries. So we'll just come off that slide. That's a worrying statistic because it shows how widespread diabetes is. And just remember, most of diabetes cases, about 95% of patients coming in with diabetes, they're type 2 diabetics. And I'm not going to go into detail today. Well, I will explain with a clip about type 2 diabetes. But just before I do that, this Saturday coming now, if you're looking at this program before the 24th of November, I just want to bring up a flyer to remind you that this Saturday, Saturday the 24th of November, at the Trinidad and Tobago Anaposis Chapel. As you know, we have a holistic center. We have the Trinidad, the Anaposis Medical Center, which is based at number 10 Lance Street in Vistabella. And then we have the church, which is the Trinidad and Tobago Anaposis Chapel. And because we have the auditorium, we have the seating capacity to hold a seminar, New Treatments for Type 2 Diabetes. And we're going to have myself and Naika Sanyo. Unfortunately, the podiatrist will not be able to make it, but we'll be talking about new treatments for type 2 diabetes. This is not just for my patients, but anybody who's interested in diabetes, or you may have relatives, you can ring on 482-4269, 482-4269, or you can just turn up on the day between 4 to 6 p.m. So I'll show that again at the end. But remember, if you're looking at this program next week, you would have missed that seminar, and we will keep you informed. We'll try and do 2 or 3 seminars next week. So we're going to talk about diabetes, and just before that, I'm going to bring up slide 7, because many patients ask me, what are the goals, treatment targets for diabetes? And now this applies to type 1 or type 2 diabetes. And you can see that there are various figures there, because on the left, you see the ADA 2016 guidelines. We have what is called the HbA1c, which is the blood test that all diabetics should be familiar with, and that should be less than 7%. Although on the right, you have the American Association for Clinical Endocrinology saying that their goal is less than 6.5. You may be more familiar with the milligram per deciliter reading. And again, before eating, which is called preprandial capillary plasma glucose, should be between 90 to 130, although again, the AACE has a more stringent guideline of less than 110, and the other blood sugar reading you should be taking is a 2-hour postprandial or 2-hour after meal reading, and the American Diabetic Association says less than 180. I prefer the less than 140, especially for our younger patients. So those are kind of the kind of goals we are looking at. And of course, that means that most of our diabetic patients should be doing some blood sugar readings. Now, if your blood sugars are very well controlled, and you can, of course, know that by doing your A1C every 3 to 6 months, you may not have to be doing a lot of readings at home. But if your A1Cs are above 7.5 to 8%, you need to be doing at least 2 readings a day, preferably 1 in the morning before breakfast, and then 1 other reading for the day. I tell my patients 2 hours after one of your meals. Now, the seminar we will be having, we'll be demonstrating some new machines for doing continuous glucose monitoring. I know a lot of patients hate sticking their fingers, and I do that occasionally, and I know it's not the most painless experience, but if you're diabetic, you can't get away from doing it, although we are seeing some new devices being mentioned where it's not as invasive. I want to go to our first clip today, and this is going to just tell you about the basics of type 2 diabetes. So we're going to go to our first clip, and then I'll come back and talk a little bit about that.
Type 2 diabetes is a metabolic disorder that causes sugar, in the form of glucose, to accumulate in the blood rather than being used as fuel by the cells in our body. When we eat, food is broken down by our digestive system into nutrient molecules that are then absorbed through our digestive tract for use by the body. Foods containing carbohydrates or various sugars are broken down into glucose. Glucose is an important source of fuel for many organs in our body. However, to be able to use the glucose for fuel, the glucose molecule must first enter into the cell. The pancreas produces a hormone called insulin, a chemical messenger essential for the entry of glucose into cells. As the blood glucose levels rise after a meal, insulin is released into the bloodstream and sets processes in motion to trigger the removal of glucose from the blood to enter into the cells. In type 2 diabetes, the cells become resistant to insulin and ignore its message to absorb glucose. This is known as insulin resistance. In addition, in type 2 diabetes, the pancreas is unable to produce the greater amounts of insulin needed to trigger these resistant cells to take in glucose from the bloodstream. The most notable symptom of diabetes is frequent urination and excessive thirst. Other symptoms include weakness, drowsiness, and blurred vision. These are caused by chemical imbalances in the blood related to high levels of blood glucose. About 1 in 4 people with type 2 diabetes are unaware that they have the disease. It is important to catch diabetes early. Over time, high blood glucose damages the blood vessels, which can damage the organs that these vessels supply, leading to a variety of health complications. Damage to the small or micro blood vessels can cause vision problems, including loss of sight, nerve damage, and kidney disease. Damage to larger or macro blood vessels can lead to cardiovascular complications such as heart disease, stroke, and poor blood circulation. Overweight and inactivity are major causes of diabetes. A family history of diabetes significantly increases your risk of developing the disease. Certain ethnic populations are also at increased risk of developing type 2 diabetes. Finally, some medications may increase your diabetes risk, specifically corticosteroids, thiazide diuretics, drugs used to treat certain mental illnesses, and some antiretrovirals used to treat HIV infection. In summary, type 2 diabetes is a metabolic disorder. It causes sugar, in the form of glucose, to accumulate in the blood, rather than being used as fuel for the cells in our body. If not diagnosed and treated in a timely manner, type 2 diabetes can lead to many health complications.
So that was a very informative overview of type 2 diabetes. And as you can see there, what we would call two basic mechanisms involved. The pancreas is not producing enough insulin, and you have what is called insulin resistance. However, and I don't have a diagram to represent this, we now know that type 2 diabetes is a much more complex metabolic disorder. There's a word or phrase we use called the ominous octet. The ominous octet. And the ominous octet is a series of pathological disorders that's happening in the body that drives type 2 diabetes. So up to a few years ago, we thought it was just the pancreas that was involved in type 2 diabetes. But now we know that the gut has an important part to play. It releases something called glucagon-like peptide, and I'll show a clip on that in a few minutes. We now know that the liver, a lot of diabetics have a fatty liver, and it's not due to statins, let me say that very quickly, or cholesterol tablets. The fatty liver is due to the diabetes, and as a result of the fatty liver and other mechanisms, the liver releases sugar into the system. And now we have a new class of drugs that's targeting the kidneys. We never knew that the kidneys actually withheld sugar in the body rather than excreting it as it would do in someone who's not diabetic. And we now have new drugs that I will talk about in terms of helping the kidney to function more effectively in excreting sugar from the body. And in fact, we also now know that the brain, there are certain neurotransmitters that are not functioning properly. So I'm saying all of that to say that type 2 diabetes is a much more complex problem. And I want to say this because I'm criticized sometimes, and in fact, after our last program, I got a WhatsApp saying that, that I need to be a little bit more cautious about what I say. But let me just say, there's a lot of fake medicine out there. I'm not going to call brands and different products, but there's a lot of fake medicine. What do I mean by that? Whatever area of work or employment, people need to be trained. And yet what we are seeing in the medical world is that people without 1 day of medical school training trying to sell products and claiming that they're doing amazing things for diabetes. I want to encourage you again to be cautious. I would say that I spent about 15 years in my training before I could be called someone with a specialist knowledge of diabetes. My daughter has just entered medical school, and she has years of training ahead of her before she's able to come out and begin to practice and begin to see patients. Yet we have many people who are trying to treat diabetes without understanding what the ominous octet is all about. Even as doctors, we need to be careful when we are prescribing that, and I want to be clear about this, that we are not treating just a blood sugar. When a patient comes in with a high blood sugar, the temptation is, let's just give whatever medication to bring that blood sugar down. Now, that's all well and good in the short term, but the drugs you choose should be patient-specific. It should be dependent on the patient sitting before you. So if you have a slim, lean, young patient presenting with diabetes, it would be different the way you treat that patient to someone who's elderly or someone who is overweight, carrying a lot of fat around the tummy area. This is the art of doing medicine. I use that term very intentionally. In fact, the dean of, the assistant dean of St. George's Medical School, when we had our orientation for our daughter's entry, he talked about the art of doing medicine, and as opposed to the science of medicine. So I can give you a lot of science, but the art of medicine is to choose the right treatment for the patient sitting before you. And that involves taking a proper history, doing a physical examination, looking at the different investigations that need to be done, and then choosing the right treatments. I want to bring up slide 8. slide 8, because these are some worrying statistics from Mexico, actually, slide 8. And I would not doubt we have a similar problem. If you look at this in the blue aspect of that diagram, only 5% of patients, diabetic patients, this was back in 2006, so hopefully it will be better now, but only about 5% of patients had an HbA1c of less than 7. About 39% of patients had an A1C of 7.1 to 11, which is relatively poor control. And over 56% of diabetic patients had an A1C of above 11%. Now, we can just come off that slide. What do I mean by an A1C of 11%? That means in those patients, the previous 3 months before that HbA1c measurement, the average blood sugar for that patient would have been near to 300. Yes, that's what you can use a certain diagram and calculation to convert what an A1C, which is a percentage figure, to milligrams per deciliter. And of course, what we are reminding you is that an ideal A1C is less than 7%, or in younger patients, around 6.5%. We're going to look at just one other slide right now, slide 10. Slide 10, because this reinforces, the writing is a little bit small there, but when diabetics are not well controlled, what happens? You have all the complications of diabetes. Now, I'm probably going to come back to this diagram because it's very important that I review some of those figures with you, but we already have to go to our first break. I want to remind you that we are pre-recorded, but you can ring on 482-4269, 482-4269. I do try my best to return all the calls, but please forgive me if I miss a few. We're going to go to our first break and then return to Your Health, Your Choice.
Looking for a safe place for the whole family? Well, now you found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values, and family first. We are ACTN The Voice, your family-friendly station.
ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. Reminding you that we are pre-recorded, so you can't ring in tonight with your questions, but you can ring us on 482-4269 during the week if you have questions, and I do try to return as many of the calls. You can also WhatsApp your questions. Sometimes that's a better way of doing it, actually, because it then gives me an opportunity to return your questions, answers to your questions by WhatsApp rather than having to call. We're talking about diabetes. Last week was World Diabetes Day, and I showed slide 10 just before we went to the break, so I just want to bring that up. And what it shows is that just a 1% decrease in the A1C. So even if you are running an extremely high A1C, which is your 3-month average, and you bring that A1C down from 10 to 9%, there's almost a 37 from the top of the slide on the right-hand side. There's almost a 37 decrease in microvascular complications. What do I mean by that? Those are the complications caused by diabetes affecting the small vessels, so affecting the kidneys, the eyes. Amputation rates can decrease by 43%. Diabetes-related deaths by 21%. Cataract surgery, lower down. Heart failure can be reduced by 16%. Heart attacks by 14%. And strokes by 12%. So, I mean, that's a mouthful. We can just come off that slide. But what that slide is demonstrating to you is that just small improvements. You know, some people come in and they're very fatalistic about their diabetes control. They think they can't get their blood sugars under control. They have been on some of the older medications like metformin and diamicron, which is what is available in the government health service, and their blood sugars are out of control. Can I just say again, and this is another request to the Ministry of Health, that we are trying to save money up front by not putting some of the more expensive drugs, as some people think, on the government service. But that's very short-sighted and a very poor economic argument, because what you're doing is by not making available some of the latest medications we have, we are not treating the core pathological defects in type 2 diabetes. So you have people on metformin, on diamicron, and sometimes even on insulin, and yet their blood sugars are completely out of control. They end up in kidney failure. Dialysis is hugely expensive. They end up with amputations, which is a really, really sad complications of diabetes, especially when someone is 40 or 50 years old. They end up with diabetic eye complications, cannot work, cannot earn, and you end up spending much more money on the health economy, in the private sector, etc., because we did not have the foresight to spend upfront to try and prevent the complications of diabetes. So what I want to do tonight is I want to look at some of the newer medications that are available. But just before I do that, I want to bring up slide 11 on the PowerPoint slide pack, slide 11. And this answers the question, why are some patients not adequately controlled? Well, if we go in a clockwise direction, there's something called therapeutic inertia. That's simply meaning that people are on drugs for years and we are slow to add in new medications. Lack of a multidisciplinary team. It's not just a doctor you need to be seeing to control your diabetes. You need a diabetes educator, you need dietitians, you need podiatrists, you need counselors. Fear of hypoglycemia. Very, very important, fear of hypoglycemia. Lack of social support. That's one that we often we underestimate. If people don't have family members at home and there's no social support mechanisms, we're going to run into problems. Now, the other one is a little bit more controversial. Fragmented governmental strategies. Yes, our infrastructure for treating diabetes is still not what it should be. And lack of professionals who are properly trained, not just doctors, but nurses, diabetic educators, etc. So one of the reasons we are struggling to get patients under control is all those factors come into play. So it's not just about coming into a doctor, seeing someone, and having some medications prescribed, because we know compliance is a big issue, diabetes education is a big issue. Unfortunately, we are still struggling to get even the post of a diabetes educator properly recognized on the government service. We are short of dietitians. We still don't have, as far as I know, any state-registered podiatrist in the government system. Now, that is appalling. Again, I would say that, we give out lots of scholarships for people to do medicine and engineering, etc. But, I would beg the Ministry of Health to recognize that maybe we should be giving out some scholarships for people to do podiatry, because it's a 4-year training program. Podiatry is not a 1-year program where you learn just to cut nails, etc. It is a full qualification, and we desperately need more podiatrists to treat people with foot problems and to prevent foot problems. What I'm going to go into now is we know about metformin, we know about sulfonylureas, but I want to talk about a relatively newer class of drugs, which are called the DPP-4 inhibitors. It's called the dipeptidyl peptidase 4 inhibitors. And there's a clip that will describe what these drugs are about, and then I will talk a little bit about it after that. So we go to our second clip at this point.
It is one of the most serious health problems of our time. It is expected to affect nearly 552 million people in the world within the next 20 years. Type 2 diabetes will account for up to 95% of these cases. It is a leading cause of death in most developed countries. Many people living with diabetes are not even aware of their condition, often due to the absence of symptoms, and may go undiagnosed until complications start to show. Type 2 diabetes is growing not just because the world's population is expanding and getting older, but also because obesity is on the rise across the globe. Type 2 diabetes is affecting more people and at a younger age. Every 10 seconds, 3 people will be diagnosed with type 2 diabetes. Every 10 seconds, 1 person will die from diabetes-related complications like heart disease, kidney failure, or stroke. Normally, when food is digested, the level of sugar in the blood, known as blood glucose, increases. However, the body has a number of complex and effective ways to ensure that the level of glucose in the blood remains stable. The gut plays an important role here. As the level of glucose in the blood increases, the gut responds by producing a powerful hormone called GLP-1. When food is consumed, the body's natural response is to prompt the gut to release this GLP-1 hormone. GLP-1 travels in the blood to the pancreas, which is a gland located behind the stomach. Here, GLP-1 works in 2 different ways. One way is to increase the amount of insulin that's made when blood glucose levels rise too high. The insulin triggers the muscles and tissues to use more energy. This reduces the total amount of glucose left circulating in the blood. The other way GLP-1 works is to hold back the production of a hormone called glucagon, which encourages the liver to convert the body's stored glucose reserves into active glucose. By holding back the production of glucagon, you can minimize the amount of glucose circulating in the bloodstream. The GLP-1 hormone does not last long in the body, as an enzyme called DPP-4 breaks it down. In type 2 diabetes, these processes do not work correctly. Patients experience abnormally high levels of glucose in their blood. This is due to 2 factors: either not enough insulin is produced, or it does not work properly. To manage their condition, each type 2 diabetes patient actively needs to control their blood glucose levels. This will reduce the risk of developing complications. Improving diet and exercise is the first step, but many patients may also require medication. DPP-4 inhibitors represent an innovative approach to the treatment of type 2 diabetes. DPP-4 inhibitors have a unique way of working. DPP-4 inhibitors attach to the DPP-4 enzymes and prevent them from breaking down the GLP-1 hormone. As a result, GLP-1 remains active for a longer time, so it can continue to act on the pancreas. There it increases insulin production and holds back glucagon production, both of which help to reduce the amount of glucose circulating in the blood. DPP-4 inhibitors can lower blood glucose levels. Over the long term, controlled blood glucose can help reduce the risk of potentially life-threatening complications, like heart disease, kidney problems, nerve damage, and visual impairment. Unlike many other type 2 diabetes treatments, DPP-4 inhibitors do not cause patients to put on weight. This is an advantage, as body weight can be a challenge to manage. When used in monotherapy, DPP-4 inhibitors are not associated with an increased risk that blood glucose will fall too low. In addition to diet and exercise, DPP-4 inhibitors are therefore an effective and simple option to help people control their blood glucose levels and type 2 diabetes.
Okay, so that was quite a comprehensive overview of the DPP-4 inhibitors. Now, what are some of these, the names of some of these drugs? Some of you may have heard about them. One is called Januvia, another one is called Galvus, there's one called Tradjenta, Combiglize. There are about 4 or 5 of these drugs available in our local market. However, none of these drugs are available in the government service. So what happens is that the thousands of patients who are going to our health centers, government clinics, they are placed on metformin, they're placed on sulfonylurea. And let me just say, sulfonylureas are cheap, metformin is cheap, but if you put someone with type 2 diabetes who has very little residual beta cell function, in other words, the pancreas has very little ability to secrete insulin, you're wasting your time because you're trying to flog a dead horse. The beta cells are not able to respond to the sulfonylureas. So here we have a relatively newer class of drugs, yes, which are more expensive than the metformin and sulfonylureas, but again, look at the kind of complications we are trying to prevent: nerve damage, amputations, blindness, kidney damage, etc. And what the slide showed is that the way this drug works, when you eat, your body should be producing something called GLP-1, which is glucagon-like peptide, from the gut. So as you're eating, the body's beginning to secrete glucagon-like peptide. This primes the beta cells and also suppresses something called glucagon, so the body can respond very quickly to your carbohydrate intake, your blood sugars, and bring your blood sugars down quickly. Diabetics lose that. So when you take, and the reason for that is that GLP-1 is broken down very quickly by the dipeptidyl-4 enzyme. So this class of drugs, which is an oral drug called the dipeptidyl-4 inhibitors, they block that enzyme, so the GLP-1 will last longer in the bloodstream and have a greater effect on insulin levels and glucagon. Now, we have the oral drugs. I don't have a clip on this other class of drugs, which is called the GLP-1 agonists. Things like Byetta, which we do have in Trinidad, not very popular, but we are waiting on a drug called Victoza. It's an injection, but it's not insulin. And then you may see one that is advertised very heavily on cable channels called Trulicity. Now, Trulicity is a once-a-week injection for type 2 diabetes. And it's becoming very popular because, of course, if people can take an injection once a week and control their blood sugars, that's great. So this two classes of drugs are very closely interconnected: the dipeptidyl-4 inhibitors and the glucagon-like the GLP-1 agonists. And I would suggest that a lot of our patients will do very well. Now, I know we have to go to a break in 2 or 3 minutes, but I want to bring up slide 13, which talks about this whole therapeutic inertia. And I want to remind, what is therapeutic inertia? It's the failure to intensify treatment despite patients not reaching targets. And there was an article in the British Journal of General Practice in 2007 that showed in diabetics, after a patient has not reached targets, physicians take an average of 7.7 years to start insulin treatment, and they do so with an average A1C of greater than 10%. I want to come off that slide and explain to you what the implications of that is. So what we are saying is that as healthcare professionals, we are guilty of not advancing treatment because we are sometimes hesitant to use new drugs. Here in Trinidad, now that was a research paper based on the NHS, the National Health Service in England, but I think we face a very similar, even greater problem here because on the government service, we just don't have the drugs. So, you know, when you have maxed out metformin, and some people go up to 3 grams of metformin, I very rarely do, because after you have reached 2 grams of metformin, you have a plateau effect. That's 2 tablets twice a day, and increasing the metformin by 1 or 2 is just buying time that you really don't have. Similarly, with the sulfonylureas, we like glycoside, Deonil. We have diamicron MR, but I understand on the government service sometimes even the original diamicron MR is not available, and there's a generic. Now, I want to say that we have to be careful about some of the generics that are coming in, because while the generics might be much cheaper, The question is, are these generics as efficacious as the original brand products? My question is whoever is making the decision, the formulary committee, etc., are these drugs actually being tested to see how the efficacy is, or are we just looking at paperwork from companies and which is suggesting that they're as good as the original brand products, and in fact, they're not being properly tested? We have to go to our second break, and time is going very quickly today. So when we come back, I will talk a little bit about another new class of drugs that's available for type 2 diabetes. We're going to go to our second break. You're watching Your Health, Your Choice. We go to our break and we'll return in a minute or two.
Looking for a safe place for the whole family? Well, now you found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values and family first. We are ACTN The Voice, your family-friendly station.
ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. Want to remind you that we are pre-recorded and we're talking about diabetes. You can ring us on 482-4269, or even better, WhatsApp your questions on that number, or text your questions on that number, and we will try and respond by text message or WhatsApp with the answers. Much easier than doing a telephone call, I have to say. So I will try and respond to as much of your questions as possible. We are talking about some of the newer treatments for type 2 diabetes, and we are saying that type 2 diabetes is a very complex illness. We talk about something called the ominous octet, and we are not just looking at the pancreas, we're looking at the various pathophysiological defects in type 2 diabetes. Now, the latest class of drugs we have available is the SGLT2 inhibitors, the sodium glucose cotransporter 2 inhibitors. And this is acting on the kidneys. It's an innovative, very exciting way of treating type 2 diabetes. So I want to go straight to the clip, and then I'll come back and talk a little bit about the use of these drugs in treating diabetes. So we now have a new class of drugs. We were waiting on this class of drugs, the SGLT2 inhibitors, for quite a while. They were launched in Europe, England, and the US. And we now have 3 in this class. One is called Jardiance, the other one is called Invokana, and the other one is called Forxiga. And it has given us a tremendous new option for treating type 2 diabetes. As you would have looked at the animation, this new class of drugs, they're acting completely independently of the pancreas or the liver or insulin resistance. It's acting on the kidneys. What we did not know many years ago is that rather than the kidney excreting a lot of sugar from the blood in people who are diabetics, the receptor site that allows this sugar to be reabsorbed, it's upgraded so people reabsorb more sugar than should be excreted in type 2 diabetics. And also the kidney can also produce sugar, which we didn't know as well. So now we have a new class of drugs which is able to block that receptor site. That's why it's called the SGLT2 inhibitor. It's blocking that receptor site, and it's causing what we call a diuresis. So you're literally urinating out more sugar. Now, initially, that might sound counterintuitive because we used to test the sugar, the urine for sugar to diagnose diabetes in the old days. That's why I don't test the urine for sugar. We should be testing the urine for protein, or in type 1 diabetics for ketones, but not for sugar, because a lot of diabetics could run very high blood sugars and they have absolutely no sugar in the urine. So this new class of drugs, which I'm already using a lot of, it can help with weight loss. It might help with blood pressure control. And of course, the main reason for using it, it can lower the blood sugar readings. And what I'm finding is, now you're not going to use this drug as first line in a type 2 diabetic, and it's not approved as yet for type 1 diabetics. But what I'm discovering is that I have a lot of patients on insulin who are insulin resistant. And when I add in the SGLT2 inhibitor, you are able to decrease the dose of insulin because you're dealing, some people lose some weight, you're helping them urinate out more sugar, and by that means they're losing calories, so you may actually need less insulin. So we are excited about this new class of drugs. It's showing heart protection as well as kidney protection. And it's also the latest data we have from the recent European Association for the Study of Diabetes meeting, which I was fortunate enough to be at in Berlin. It's also showing protection against heart failure. So we have a new class of drugs that is available. We also have some new insulins on the market, and I know we don't have much time, but I'm going to go to our last clip, and this talks about a new insulin that we are waiting on called Toujeo, and it's a form of glargine, Lantus, but it's a more concentrated form. So let's go to that slide quickly.
Hey pharmacist, here's the difference between the ever-popular Lantus and the newer concentrated Toujeo. Both of these pens contain insulin glargine. They're made by the same manufacturer. The only difference, or so it would seem, is that Lantus comes as 100 units per ml, and Toujeo comes as 300 units per ml. But there are a few meaningful differences that you should be aware of if your patient is switching from Lantus to Toujeo. Number 1, don't be confused by the word concentrated. A common misconception is that if you switch your patient from Lantus to Toujeo, they'll be able to inject fewer units of insulin because it's 3 times more concentrated. But that's not the case. Let me give you an example to put this into perspective. Say you have a patient who's on 60 units of Lantus and you're switching them over to Toujeo. So if it's 3 times more concentrated, you may think that you're switching them over to 20 units of Toujeo. But unfortunately, that's where the confusion lies. The patient would get 60 units of Toujeo to start because it is a 1-to-1 conversion between Lantus and Toujeo. The only difference is that the volume injected into the patient will be smaller with Toujeo. So that actually might be more comfortable for your patient if they are injecting more units of insulin per day. Number 2, patients on Toujeo may actually need to inject more insulin than when they were on Lantus. So I just mentioned that when you're switching someone over from Lantus to Toujeo, it's a 1-to-1 conversion. However, over time, your patient actually may need more units of Toujeo in order to achieve target blood sugar levels. In fact, this could range anywhere from 10 to 17%, which can be surprising because you probably thought that this was a more concentrated insulin and they wouldn't need as many units. But in fact, it actually is working the other way. Doesn't it seem odd that a more concentrated form of insulin would require a higher dose? That's my next point. Number 3, there are significant differences between these two products. Toujeo actually has a more gradual onset and a longer duration of action, so about 30 to 36 hours, whereas Lantus is 18 to 24 hours. The advantage to your patient is that they may experience fewer episodes of hypoglycemia at nighttime, and that could be the reason why they were switched over in the first place. However, it does take about 5 days to reach steady state with Toujeo versus Lantus, which is about half that. So keep that in mind as you're titrating your patient, because you may have to do that more slowly than you're used to if you're more familiar with titrating someone on Lantus. Number 4, and this is the last one, they actually cost about the same. You may look at the cost of the two pens and see that a box of 5 Toujeo SoloStar pens costs more than a box of 5 Lantus pens, except there's a trick. The Toujeo pen contains 450 units of insulin and the Lantus pen contains 300 units of insulin, so you're actually getting 150 units more in this Toujeo pen. And when you do the math, which I did, the per unit cost of insulin is actually pretty much the same. So don't think of this as a more expensive insulin. What would make a difference is if your patient actually needs to inject more insulin with the Toujeo versus their Lantus, and it actually does cause that price discrepancy. Here's the bottom line. Don't necessarily think of Toujeo as an option for patients who need high doses of insulin. It could be more comfortable for them because they would be injecting a smaller volume of insulin. But other than that, it is a 1-to-1 conversion. So they're actually not injecting fewer units of insulin, and in fact, they could actually end up injecting more. And the two products are not interchangeable. So keep that in mind if your patient is being switched over, because there can be meaningful differences and it can impact their blood glucose levels at the initial point.
Right, so that's what was our last clip for tonight. And what I've tried tonight to do is to show you the range of new treatments. And there are lots that I haven't mentioned because I haven't had time. But this Saturday coming, so if you're watching this program before the 24th of November, I'm just going to bring up the flyer again. At the Trinidad and Tobago Anaposis Chapel. So we have a holistic center. The Anaposis Medical Center is still located at number 10 Lance Street in Vista Bella. But the chapel, which we address the emotional, mental, spiritual aspects of a patient's overall health care. On Saturday, 24th of November, this Saturday coming, 4 to 6 p.m. It's open to anyone. You can turn up on the day, or you can ring us on 482-4269, 482-4269, and that's the number also to ring in on your questions, etc. So I want to close off tonight, this evening, putting on my pastoral hat again. And just this morning, I was looking at what I would call the root of bitterness. You know, you meet some people and they're quite bitter in life. But when you have experienced the grace of God, I think it changes your life. In fact, I know it changes your life. A grace-filled people or a grace-filled person is graceful. I want to repeat that. That's an important word or phrase to remember. If you are filled with God's grace, you cannot help but be graceful. The writer of the Hebrews says in Hebrews chapter 12, see to it that no one misses the grace of God. When you miss the grace of God, the writer goes on to say that a root of bitterness can grow in your life. I want to say this to you, that religion without grace is poisonous. A relationship without grace is poisonous. A church without grace, yes, a church without grace is poisonous. A heart without grace is poisonous. The bitter root may be small and slow in its growth, but eventually the poison takes effect. Can I say this to you as I close off? That grace is powerful enough to erase your guilt. Grace is big enough to cover your shame. Grace is real enough to heal your relationships. Grace is strong enough to hold you up when you're weak. Grace is sweet enough to cure your bitterness. Why did I choose to close off on this? You know, even meeting my patients, I often say to our church that I do more ministry in my medical office. What do I mean by that? I don't mean that I pray with every patient that comes through the door, or I try to convert them to my way of my faith philosophy. But by a simple smile, by a gentle touch, by being willing to listen to someone, very often we demonstrate the grace of God to others. Can I say that I often say to our church, I'm fed up with religion. I'm burnt out on religion. I've had enough of religion. You know, I saw a clip the other day where in a certain country, in the highest office of the land, there were people praying. Now, I applaud that. But praying is not enough. It is what follows the prayer. Going to church or your temple or your mosque is not enough. It's what follows that. Does it really change my life? Do I have care for the poor? Compassion for the strangers in the land, care for the refugees who are trying to enter our countries, even here in Trinidad, people from Venezuela who are coming in. As a Christian community, how do we respond? We should respond with grace, because grace is what changes people. For too long, can I say, we have played with religion. We have even played with healthcare. I think it's time we take what we believe seriously and allow it to impact the way we treat others and the way we interact with each other. As I end with Your Health, Your Choice tonight, can I say to you, bitterness can even affect your physical health. Why not get rid of bitterness and allow God's grace to fill your life? You've been looking at Your Health, Your Choice. Thank you for joining us. This program will be replayed several times, and we will come with a new program in 2 weeks' time. I'm Dr. Claude Khan. Thank you for joining us on Your Health, Your Choice.